So I'm from National Guard Jeddah, and we are ablaters as well. Like what Dr. Faiz said, we ablate everyone except if they are bedridden, demented, or if they totally refuse ablation. We believe that ablation works, and ablation is very low risk with great success rates. And this strength is more clear and more evident, with no doubt, in patients with heart failure. So if you have heart failure, you're done. This patient is going for ablation. And remember, your discussion with the patient makes a big difference in the decision, right? So the way you put the ablation procedure and the way you tell them about the risk and the success rate and your own statistics in the center makes a big difference in the decision of that patient. So slides are not moving. Okay. So today I'm gonna review the coexistence and consequences of AFib and heart failure, the role of rhythm control in heart failure patients. I'm gonna review the proper timing for referrals, the overall safety, and should we apply this data over the general population from the randomized trials or not, and how to improve patient selection and pace and ablate approach. So first, atrial fibrillation and heart failure are two emerging epidemics in our community and worldwide. Prevalence of both will be increasing with aging population. And in the US by 2030, it's estimated that 12 million people will have AFib and 8 million will have heart failure. And AFib and heart failure tend to coexist together because they share many of the risk factors. So I'm not gonna go into details because I have too many slides. It's a circle. The more heart failure you get, the more AFib you get, and the more AFib you get, the more heart failure you get, whether with reduced ejection fraction, with preserved ejection fraction. And we know that AFib begets heart failure and vice versa. And if you look at the study, patients with heart failure, the incidence of AFib increases with time over the years. And patients with AFib, they have more heart failure with time. We're talking about heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. And we know that patients with AFib, if they develop heart failure, their mortality rate increases. Same again for both reduced ejection fraction and preserved ejection fraction. So what's the role of rhythm control in heart failure patients? So we'll go with a case. This is a 55-year-old, came with shortness of breath and palpitations. He's diabetic, hypertensive. Echo done showed ejection fraction of 25% on medications that was started, and cath showed normal coronaries. So global hypokinesis, referred to us in the clinic for ICD implantation. So the ECG is atrial fibrillation, and we know that drug therapy works in heart failure. And we know over the years, this improved a lot with adding different generations, with ARNIs, with SGLT2 inhibitors. And overall, we have 20 to 30% risk reduction and reducing in mortality with heart failure medications. But as electrophysiologists, can we help in that regard? Yes, we can help with ablation. So this same patient, what we went for TE-guided cardioversion, we kept him on antiarrhythmics and anticoagulation, and we did PVI isolation. You can do PVI, you can do with posterior wall as well. I'll talk about that later. And echo done after a few months showed normal ejection fraction. And we have many success stories like this in our center, and I'm sure all EP centers across the country and worldwide have the same success stories. So ablation works with atrial fibrillation, and you'll be surprised. We've done patients with severe left atrial dilatation, with lots of scarring in the atrium, and ejection fraction becomes normal after ablation. And the patient will not have an ICD will not have a CRT-D. You avoid all the complications of device implants because of a simple procedure. Okay, so medications, they don't work very well for patients with persistent atrial fibrillation and heart failure. They have lots of side effects, as Dr. Faiz mentioned, and should not be used in this patient population with structural heart disease. So, and if you use medications like amiodarone, you run with long list of side effects. It works and it's effective, but long list of side effects for these patients. And we have better options. So we know that rhythm control using catheter ablation works. Not in one study, in many, many studies. I'm gonna go over the major ones now, but we know for sure that ablation decreases mortality in these patients. So one of the three biggest trials, the ATTACK, the CASTLE-AFib, and the Qubbany heart failure, all show superiority with pulmonary vein isolation. So we'll go over the ATTACK trial where the patient went for ejection fraction less than 40%, NYHA 2 to 3, and they have persistent atrial fibrillation, all went for PVI plus additional lines, additional ablations based on the ablator's preference. And at the end of 2 years, the probability of sinus rhythm was 70% versus 34% in the amiodarone group. And this also improved if you do posterior wall isolation in the study from 80% to 36%, and decreased hospitalization, decreased mortality, and very low complication rates. And we have to underline this, very low complication rates with catheter ablation. So we know that its catheter ablation is effective in ATTACK trial. What about the CASTLE-AFib trial? Huge trial. Patients went for ejection fraction less than 35%, NYHA 1 to 4, persistent atrial fibrillation in more than 50% of patients, PVI plus additional lines as needed. Mortality improved significantly. But look at that. Mortality benefit appears 3 years after ablation. So don't rush mortality benefit. Ejection fraction will improve. Follow up this patient, continue medical therapy, and you will see benefit. And hospitalization also improved with ablation. And AFib burden significantly improved better with ablation than medical therapy. This persisted? Yes, this persisted for many, many months. So mortality benefit persisted, events less with ablation, and up to 60 months after randomization. So this, in the subgroup analysis of this was mainly, we noticed two things in the study. We noticed that patients with NYHA class 1 to 2, they did better than patients with NYHA class 3, which makes sense. Patients with ejection fraction more than 25%, ablation was more beneficial. Patients with less than 25%, ablation was not statistically significant, beneficial. But there are other studies that support ablation even in low ejection fraction. I'm going to talk about it. So third study is the Qubbany heart failure trial, and it included patients with NYHA more than 2 at baseline. Only 9% of patients had ejection fraction less than 40%. The rest were higher. PVI plus additional lines, and again showed the same results. Primary endpoint better with ablation than medications, and mortality rate much better with ablation than medications. And as you noticed, this started from the atrial fibrillation burden improved at 12 months, but also maintained at 60 months. So ablation works early, and ablation persistently works as well. So we know from major trials that ablation in heart failure is effective and safe. So what about patients with severe heart failure? So this was published last year, the Qubbany heart transplant trial. And it's a single center trial but I think it was very useful. It stopped early because of efficacy. So they took 90 patients in the transplant list, and they ablated these patients. And compared to medical therapy, there was a huge mortality benefit. Not just that, so mortality improved, needing left ventricular assist devices improved significantly with catheter ablation, to the extent they had to stop the trial because of efficacy. So although it's a single center trial, but it gives us the courage to go for even very sick patients. Because I see many centers don't refer patients because of their general condition and their frailty. And if the patient is young, even on the transplant list, he's fit for ablation. Okay, so what's the proper timing? As Dr. Faiz mentioned in the previous study. So this patient is another case, 53-year-old. Again, EF 25%, with medical therapy became 33. EF showed, ECG showed atrial fibrillation. So we did PVI, and echo improved, but then he came again after 10 months with atypical flutter. So we took him to the cath lab, and again, these patients will have 3, 4, 5, 6, 10 flutters, and you can spend your whole day there, okay? So that's why we should refer these patients early. The earlier you refer the patients, the better success rate we will get, either in heart failure patients or without heart failure. Your patient, because most of you are general cardiologists, you have a patient with atrial fibrillation, refer him to electrophysiologist, period. Even if it's one episode, refer him to electrophysiologist and he will take over from there. Either he will go for ablation or he will discuss with the patient what's the next step. Don't wait and say this is only one episode, we will wait for 3, 4 years. Then they come to us with severe left atrial dilatation and heart failure, and then the success rate is lower. So EAST AF-NET trial, as Dr. Faiz mentioned, ablation early was much better than usual care for these patients. Mortality benefit, stroke benefit, hospitalization benefit. So the median time for ablation was 36 days from diagnosis. This is very fast. So the patient was diagnosed with atrial fibrillation, go for ablation, and you get better success rates. So is it safe, AFib procedures? We know for usual patients without heart failure that it's a safe procedure. We code the patients around 2%, 2 to 3% risk of complications. So we know it's a relatively safe procedure. Risk of death is way below 100, and risk of stroke is 100 or less. We've never seen that in our center, and we know that it's done safely in most cardiac centers across the kingdom here and across the world. What about in heart failure patients? So many studies reported similar results for complication rates with patients in heart failure. So you code the patients almost the same risks, and you advise them to go for ablation. So it's an effective procedure. We should consider it early, and it's a safe procedure. Should we generalize these RCT data to the general population? Let's look at because remember, Castle AFib criteria was very strict. So let's see if we apply this criteria across the board, is it still effective or not? So from 3,000 patients screened, they only enrolled 10%, which is 390 patients. But let's see. So if you look at the studies from Canada, these population registries, we see similar results. We see similar mortality benefit in heart failure patients. We see similar impact on quality of life and hospitalization. Same thing with US data. We see similar mortality benefit, especially if you use the same criteria for Castle AFib. So if you use Castle AFib criteria, you see benefit. Even some of the failed to meet the exclusion, but the inclusion criteria, but the one with the exclusion did not see clear benefit in the population data. And that makes sense because these are very sick patients, very high risk. They were excluded from the study because of that. But in the general population, most AFib patients with heart failure will have a great success. What about how do we improve the selection of your patient? How do we know this patient, if I do ablation, heart ejection fraction will improve. This patient, ejection fraction will not improve. So recently, there was this criteria, the score that you can use, and you can use it for every patient in your clinic. And you can, with this criteria, you can somehow predict this patient, there is a good chance of recovery to the LV. This patient, there is a poor chance of recovery. And it includes whether it's a known etiology or not for the heart failure, includes cures duration at baseline, includes the paroxysmal or persistent AFib, and how big is the left atrium. It includes many things. And if you have 0 to 1 score, the risk of LVF improvement is more than 90%, which is great, right? But if you have lower than that, if you have score of 6, for example, the chance of EF improvement is very poor. So was this validated? Yes, it was validated in 8 centers in Europe and published in 2023, and it showed similar results. So if you are score 0 to 2, your chancehood of recovery is very high. So I encourage you guys to use it in your daily routine, and it gives you a prediction. When you talk to your patient, your AF might likely improve or not. But we have a gray zone what to do with these patients with score of 3 and 4. I would advocate for ablation if these patients they don't have much hope anyways with severe heart failure. Can we use MRI? Can you use other tools to help you? Yes. So the more fibrosis beforehand, so we use it for very selective patients. In patients with heart failure, the more fibrosis you have, the less likely you will have benefit from ablation. The last resort, but it's not a failure, it's a last resort, is pace and ablate. So when you have a 90-year-old, like this patient, female, bedbound, comes every few weeks to a few months to the ER with very fast heart rate, 150, 160, what to do? You're not going to ablate her. So one option is to, in this case, we went for microimplantation and ablation at the same setting, and if you know the ablation. But for younger patient population, if you consider this approach, you should go for CRT, and this is backed by evidence. We have a couple of studies that showed this actually improves mortality. So if you go for pace and ablate approach, it improves mortality in heart failure patients where you can't go for atrial fibrillation ablation. So I would not consider it as a failure, but I would consider it as a last resort option, as a palliative option with improved mortality in these patients. So the general scheme for management of AFib in heart failure patients, evaluate the rhythm for rhythm control by whether this patient is a candidate for ablation or not. If he's a candidate, push hard for ablation. So in conclusion, catheter ablation, when done in properly selected patients, can improve ejection fraction and will improve mortality, inshallah. Catheter ablation referral should be done very early, and it's a safe procedure. Consider scoring system for giving your patients a prognosis. Consider using alternative investigations like cardiac MRI in some selected patients. And AV junction ablation with pacing is not a failure, and it can improve mortality as a last resort for AFib patients. Thank you very much.